usual to say at the outset, I thank the organizers and blah blah and all that, and thank you for inviting me from all over, from my busy schedule. I took myself on. If I didn't want to stand here and talk, I wouldn't come here. So it's my garage more than your requirement, So all these guys who come and say, oh, I came from a long distance, etc. Bullshit. Sunday morning we have to be out of town. I don't do this anymore. So that the time when I thought it was important to protect my intellectual property, until I realized I don't have any. We're talking about examining the hand and trying to make sense of what you see when you look at a hand, right? In your exams, I'm sure you get different varieties of cases, some of them short, some of them long. One thing to remember when you see your hand case is that usually the examiner is also all at sea as you are. Very few examiners will have thorough knowledge of the hand as such, because hand forms such a small part of our training. And more often than not in private practice and in medical colleges, I think, I don't know except the Ganga guys, but I don't know whether you get to see hand at all. Do you get hand trauma? It all goes to the plastic guys. I want people to say yes or no. If you're not going to say yes and no and things like that, and you're not going to start talking, then I'm going to go home early. Lots of pubs are open today. Last night they shut very early, so I have to get my quota. So you don't get to see much of hand, right? So when you get a hand case, don't feel dejected. It's not so bad because the examiner also is on a sticky wicket. So you can easily, with some logic, get across. Yeah. Now, some tests are important to know by name. Very often it's more the practical application of these that is important. So you must know what you're trying to get, and each test in any part of examination, each test must serve a purpose. When you do a test, you should have something in mind. Why am I doing this test? And what information am I going to get from this test? Number one, to diagnose or confirm my diagnosis, or at least whittle down my diagnosis to a small set of differential diagnoses. That's one. The second thing is it going to help me in staging what is happening or in the treatment of what I'm going to do? Unless a test serves these functions, it's of no use doing the test, it's of no use knowing the test. There are many superfluous tests. There are many tests that each one of us, when we sit and study, we want to find out the most rare thing and psych the hell out of your colleague in the next morning and say, what is Durkan's test? And then you go, oh my god, I don't know this test, So that kind of thing does happen. So don't get worried about the names and things like that. Lots of names are attached to a lot of tests, so you don't need to worry about all of that. The next thing about hand examination is the fact that you cannot go in the way that you normally go, that is inspection, palpation, percussion and auscultation. Because percussion and auscultation, there's very little use of that in the hand, except when you're dealing with vascular problems. Percussion, it's basically eliciting sound, and that is really of no use in the hand. So basically you can't go from one to the other in the logical fashion that you're trained to do when you're doing hand cases. So when you look at a hand, you look at what you're dealing with. Yeah. So you have to add a couple of things to this. That is range of movements and sensations and vascular sufficiency and functional assessment. Now all this is very nice to put up on point forms and all that, but what you must remember is when you're writing down your paper, in your exams, you are expected to know everything by heart and tell the examiner, well, this patient has this and that and the other. The problem is when you're dealing with the hand, you're dealing with multiple different small joints moving at different rates, and the amount of range of movements at different joints are different. It is not humanly possible in 5 minutes or 7 minutes or 45 minutes to remember each one of this and reproduce it perfectly well. So you're going to make a mistake. And the moment you say that there's thumb adduction of so and so or thumb abduction of so and so, and the examiner sees it's not, he's going to pull you up. your exam starts dwindling down at that time. It's already you're losing something with the examiner because he's found, I told you in the beginning, the examiner is also out of his depth over here. When he sees that, oh, the patient has got so much adduction or abduction and this guy's made a mistake, so he's got a clinical sign on which he's going to pin you down. So write it down and tell the examiner that since various joints are involved and I may tend to forget, I have made a note that this joint moves at so and so range, and always remember that the active range and the passive range need to be measured, because a lot of it depends on your interpretation, as well as what you're going to suggest as form of treatment will depend upon the difference between the active and passive range of movements. If there is an active range and no further passive range, then any surgical procedure will need to think about doing something to get a further range of movement in the joint. But if there is an active range beyond which there is a passive range, that means the motor, the muscle or the tendon or the nerve that is moving that particular joint needs to be also taken care of. So you already indicated to the examiner that I know the difference between the active and the passive range and the importance of the two. So that's how you show what you have. You have very little, but you still are able to show it in a good light. Okay? Don't forget sensations, and don't forget sensations. Very carefully examine sensations. Always for the exam carry your little wisp of cotton. That's extremely important, and always test it not cursorily, because if you miss out something in sensations, you may be missing out something that the examiner is waiting to pounce on. Okay? Vascular sufficiency, again, it's fairly easy to find out, but you must remember tests like the Adson's test and the test to find out whether the Allen test, whether the arches are competent or not. Okay, so let's see whether we can go ahead and try and find out what is wrong with this patient. Suppose there's a patient like this. What do you think? What is first in your mind?
Tendon injury.
You're looking at a tendon injury. Yeah, it seems fairly simple to diagnose. The patient has been asked to flex his finger. Whether the wound is healed or not doesn't matter, but if he cannot flex, the chances are that he's got a tendon injury. Right? Now suppose it's a long-standing thing and he's not able to flex his finger, and you're not able to passively flex it also. Then there's a difference in what you tell the examiner, and there's a difference in how you're going to proceed on the case. You first get back the passive movements and then give him the motor. So your treatment will be physiotherapy first, or splintage and physiotherapy first, and then surgery. Whereas if it's something where there is passive movements, you can straight away go on to surgery. So there your examination is helping you to divide and to plan out what are the steps. Okay? What else will you look for when you see something like this? Anything that underlies the superficial scar or the skin scar has to be examined. That means the nerves and the vessels. Don't miss out. A flexor tendon will stare at you in the face. Right? He's unable to do that, but the sensations and the vascularity are not going to tell you that, whether it's there or not. So you can do an Allen test for each finger as well to see whether the nerve, the vessel on that side is interrupted or not. But there may be a lot of collaterals which develop at different levels, and therefore there must be a fairly good blood supply distally. So that may not be a good test. But the sensations, there's going to be no connections from the other side. There's going to be very little overlap. So you're going to have an anesthetic area or a paresthetic area. Also, when you see something like this in a little older, after the wound has healed, what else would you look for? Suppose the sensations are less, then what is the next sign that you look for? Tinel sign. Yeah, speak up, don't worry, I'm not going to eat you up there. If you're wrong, well and good, I'm also going to be wrong sometimes. Okay? Now this is another patient who is now able to flex, but not completely. So what is probably the problem there? Pardon? The profundus could be injured. So you're also looking at the anatomy through your examination. So your examination is supposed to illuminate anatomy for you in your head. Okay? So here's a patient who is unable to get complete flexion. There could be another reason. What could be the other reason? Stiff joint. Right? So So there again you come to range of movements, active, passive, not possible, possible, and individual testing of the sublimis. And I'm not going to go through all the basic stuff. I'm sure you guys do read, and if you don't read, then you're shameful fellows. Okay? So FDS and FDP, examine both of them separately and make a note of it. So you know that the active movements in one is not there. There's also another reason why this can happen. These are, when you see a finger like this, these are the things that could go wrong. Now you only mention the FDP. It could be a stiff joint, it could be an adherent tendon. That means there is a passive movement but no active movement because the FDP is stuck, it may not be cut. Or there may be a loss of the pulley system. If the pulley system is not competent, you're not going to get flexion at that joint. If the DIP joint is not going to flex, which pulley is not working? A4. A2 and A4. These are the two main pulleys. A2 and A4. So again you're getting an anatomical idea through your examination, having ruled out some things, what you're headed towards. Okay? So A4 pulley. Now where's the A2 and A4 pulley? I'm the examiner. No, I'm the idiot who wants to just trouble the hell out of you till you say, I'm sorry sir, I don't know. The aim of every examiner who comes to an exam is to make every child say, every student say, sorry sir, I don't know. That's like the victory, and he says, good boy. It should be the other way around. When you say I don't know, you should say bad boy. No? But then they always feel good when you say I don't know. Don't say I don't know on the first question, you'll fail straight away. But when they lead you to a point and then you say I don't know, then they're damn happy. A2 and A4. Where is A2 and where is A4?
A4 is at the medial phalanx. A4 is at between medial phalanx.
Yes.
And, A2 is at the proximal phalanx.
Where in the middle phalanx and where in the proximal phalanx?
Shaft, not at the joint.
Shaft. Still where, this is so that everyone else also understands and remembers. Okay, I don't think I have a picture of the pulley system, but I love to talk about this simply because it once and for all, for your whole life, you'll never forget this. A1, A3 and A5.
At the joints.
They are on the joint. They are on the volar plate. Okay, so A1 on the MP joint, A3 on the PIP joint, A5 on the DIP joint. So that remains, that leaves behind only A2 and A4. A2 is on the proximal phalanx and A4 is on the middle phalanx. A2 is on the proximal part of the proximal phalanx. A4 is in the middle part of the middle phalanx. Absolutely clear, and there's no doubt about this. In between there are the C's to complicate the issue, we won't go into that. But once you know this, when you're doing surgeries in your private practice or when you get out and finish and you do your surgeries, then you know the two places where you're going to be extremely careful are the middle part of the middle phalanx and the proximal part of the proximal phalanx. Finished. The rest of the pulleys you can just cut them and nothing will go wrong. You'll still have tip to palm 0. Tip to palm means from the fingertip to the palm. That's another way of clinically telling the examiner that the flexion is incomplete. So when you talk about flexion, you say, sir, there's so and so range of movement, and you say the tip to palm distance is 1 centimeter or 2 centimeters or 5 centimeters. So you should have measurement of tip to palm showing you the competence of the flexor system. So the tip to palm is an important parameter to talk about in the exams. Also, in your paper, if you write this down, when the patient comes back to you for follow-up, when you write that tip to palm is now improved, you know exactly that the range of, you get an objective idea of what is improving. Okay? We've already discussed this, that passive movements are present, FDP is absent. Okay, here's another patient with the same thing. One thing you look for when you're dealing with the little fingers, you look from the side. And can you see the, is there a pointer? Can you see this? This looks like an X. When there's incomplete flexion, it looks more like a Y. So clinically, when you're looking at it from the side, you can see whether the formation of an X is there or not, or whether there's a formation of Y, and that also leads you to look at the DIP joint. So keep looking at all of these small things that help you out. This is just the patient getting operated. Here's a patient who's got extension looking good, but when the patient flexes, what is not flexing? The MCP joint, right? Or the metacarpophalangeal joint. And what is the surgeon trying to do there? He's trying to show you the passive movements. So this is what you do when you examine the patient. When there is a range of movement deficit, you try and passively push it down. And when you cannot, then you know there is a stiff joint there. Okay? This is after the surgery. It's okay. It's a good result there. Don't worry about the results. I'm not going to open those videos and show them and things like that. Okay? The other one is an adherent tendon. Now, how do you differentiate the adherent tendon? That there are passive movements. There is no joint stiffness, but there will be scarring. Yeah. So you'll see a scar, and you'll see that the patient is unable to flex. Yeah, but there is passive movements. Okay. And you'll find adhesions like that when you're doing surgery. Okay. So that's what is preventing the tendon from actually moving. And eventually you'll get movements in that case. And the last one is when there is a loss of the pulley. Now you can see the bowstringing in this one. So how do you highlight the bowstringing? You resist flexion. You make the system incompetent. There is incompetence which is hidden inside the palm. So you resist it and you allow this bowstringing to occur, and you can demonstrate it then. Okay. And the easiest way to show that the bowstringing is the cause is to put a tight band or a ring from outside which acts like a pulley externally, and therefore you are seeing the flexion is much better just with that little tape around the finger. So if you do the same operation from inside, it's going to help. So it also tells you that this is all that is required for this case. So treatment also, from your examination you get an idea as to what is happening there. Okay. Now what seems to be the problem here? In flexion of the wrist, the patient is able to extend the finger fully. When the patient extends the wrist, pardon? Yes. It is a way. It's demonstrating that something is stuck somewhere. Okay. There could be a rupture or there can be an adherent tendon. The reason is this: the patient had this surgery done. Yeah. What kind of a fixation is this? There's only one way to describe it. It's a bad kind of fixation. No, but this is one of the techniques which is called the intrafocal Kapanji technique. Yeah, where the barber, when you're cutting your hair, the barber always taps you on the head and you always look down. So to keep the distal radius looking down, what Kapanji suggested was you put a wire which is extra, not through the fragment, outside the fragment, but intrafocal into the fracture site itself, and keep this looking down. People carried it a bit too far with multiple wires like that, and that is not a good position, and that's what happened. So after a tenolysis, the extensor tendons get stuck. So if the extensor tendons get stuck at this point, there's a fixed length phenomenon between this and this. So when you say a fixed length phenomenon, you must know across which joint is this fixed length occurring, because then you can devise your treatment along that. It's not a VIC. It's not that you're going to do a release here and get it, because the adhesions are here. So you see where your fixed length is occurring, and your treatment will then change. So although it's a fixed length phenomenon, it's a fixed length because of adhesions, not because of a tight compartment which caused a VIC. Okay. So although it looks very similar to what this is a true Folkman. Yeah, you extend the wrist, fingers can close. The moment you start flexing the wrist, the fingers open out. Okay. So this is a true Folkman, and that's the cause where everything was adherent at that point. He was released completely and he got a complete range of movements. Okay, you know what quadriga is? You read about quadriga? Yes?
When we flex the finger, sir, one finger is not flexing, it is lagging behind.
One finger doesn't flex too well, or maybe even two fingers don't flex too well, maybe three fingers don't flex too well, but one flex is good. Why does that happen? Very good, very good. So when you have 4 horses and you have 4 lagams, yeah, you're pulling the reins of 4 horses, When all four are together and exactly at the same length, the horses are free to run. You rein one fellow in, the others are going to slow down also. Correct? The same way, see the short tendon? When you have an injured flexor tendon, profundus or sublimis, when you tighten it a bit too much to overcome a gap rather than graft it, then this is what happens. You see, when you stretch it, it becomes thinner, and see what happens to the adjacent tendons. They become loose. When a tendon is not at its good length, it becomes incompetent. So it cannot flex. This is what quadriga is. Okay? Now what is this condition? Say only claw hand, and you are asking the examiner, is it a median or an ulnar claw hand? Then you say, sir, it's a, then you're worried. Why are you worried then? Once the examiner asks you a question like that in a loud voice, then you're a little worried. What are the two conditions in the hand? What are the two conditions or the two things that you will think of when you find that there is clawing and the examiner is getting a little worried? When you say ulnar claw hand, are you sure it's an ulnar claw hand? And what is he looking for? There are two abnormal communications between the median and ulnar nerve. Do you know the names? Martin Gruber and Ritchie Canis. So most examiners will remember one of these names. So they might sometimes prompt you to come out with this. So you should keep this in your mind. Martin Gruber is up here in the forearm. The Ritchie Canis is usually in the palm. Okay, and it's an abnormal connection, and therefore some more intrinsics may be supplied by one of these nerves. So although there might be a median nerve paralysis, you may not find it to be very clear on your clinical examination, and there is about 20 to 30% chances of this. But don't bring it in to confuse the examiner or to fight with the examiner in any argument. It does not happen. In clinical practice, we practically don't see, I don't know if I'm right or wrong, but we practically don't see very many of these. At least the ones who get injured don't have it. And the ones who are not injured are happily living around it. So don't bring it into an argument. When he prompts you, you must come out with the name quickly, because then he moves on. He thinks that you're a superior student. You're all this time trying to just establish one fact. My shana hai. Okay. So what do you look for? You look for wasting in the first web. Okay. And you also look for these various signs. Okay, now some of these examiners are chaps, some of the older examiners are chaps who worked a lot with leprosy. So they'll know a lot about these signs. So you need to know a little bit. The newer lot, leprosy is not very common, so they wouldn't probably know very much, but they might remember some of these signs. So you must know what is each of these. Clawing is very clear. It's called also the Duchenne sign. It's a very simple thing. You see that the intrinsics are not working. What do the intrinsics do normally? Exactly, it initiates the flexion of the metacarpophalangeal. It prevents hyperextension and initiates flexion of the metacarpophalangeal joints. That's all it does. Okay. The Froment sign is very clear and everyone knows. The important thing to do is to tell the patient to press down from here and on the normal side. Okay. On the normal side, if the patient doesn't know what to do, he will also flex on the normal side. So tell the patient, when you're giving that piece of cardboard or paper or card paper or whatever you're interposing in between, tell this patient that you do not flex your thumbs, press down directly and press with all your force. So when they use only the adductor force in the normal side, then your test is looking positive. Otherwise, both sides will go into flexion and you'll be confused. And in an exam, the slightest confusion means you're in big trouble. Because you start doubting yourself. You want it to be an ulnar claw hand because you know everything about an ulnar claw hand, but it's not fitting in because the other side is flexing. It's not flexing because you haven't spoken to the patient. So explain to him that he only does this, and you'll find that the other one automatically goes into flexion, and that is Froment sign positive. Okay. What is Bouvier's maneuver? Bouvier's maneuver is replacing the lost intrinsic power. If that allows the correction, it is also directing your attention to the treatment. So it's a sign, you can say that in the exam if you know the name, but it also then tells you already what treatment you want to do for this patient, because it's telling you that if you correct the MP joint flexion, the IP joints are going to straighten out, the claw is going to disappear, the patient is going to be happy, and that's exactly what you want. Okay? So the Bouvier sign is not only a clinical sign, it's also an indication for what treatment procedure you're going to tell the patient. And the last thing is the curling up of the fingers. You know what happens when you have a claw hand, median and ulnar claw or otherwise. They cannot close the MP joints first and then close. So if they want to pick up something, they cannot do that. What happens first is the FDP and FDS start closing first and curls upon itself. So it's just rolling up like a mat. You want to roll up a mat, the fingers just roll up like that. So they are unable to hold anything directly. So what do they do to hold? They will trick you by hooking their fingertips to the object first. So they'll do this and then lift it up. So when you see that, see, normally when you want to pick up something, you'll go like this with your MP joints flexed and you'll go and pick it up. But if they first hook their fingers and then pick it up, that's the only way, because they know the forces are now going to move this object towards the palm, which is the aim of the whole action. So again in the exam, the patient might just grasp something and take it, and you won't see the curling occurring. So look at it from the side, ask the patient to hold this position and close the fingers, and if the patient does this, then you know that there is curling up of the fingers happening. Okay. Also look for sensations in the ulnar nerve. Don't forget differential diagnosis. One of them which I have told you is abnormal anastomosis, which might be giving the ring finger the intrinsics from the median side, right? And the other is a traumatic boutonniere. So take a proper history. Although it looks like a claw, very much. See the upper finger? You might have that in two fingers happening. So be very careful as to what is the problem. Okay? And don't forget to look at the nerve along its course. So once you identified it's the ulnar nerve, it can start right from the brain to the hand. If it's in the brain, it wouldn't be in your exam usually. Yeah? If it's from the brachial plexus, well, yes, it can be in your exam. So be careful, look for the brachial plexus as well. But the one point you won't forget is to examine at the elbow. Very, very important. Examine the nerve, examine the opposite side. Roll it under your finger, feel for the paresthesias, feel for the thickness, feel for bogginess, feel for abscesses, and look for this also. This is a very common thing that happens. Can you see that? What's happening there? You see the snapping of the nerve? It's very common cause for paresthesias and early clawing in the ulnar nerve. So you look for tardy ulnar nerve palsy following what? So you look for tardy ulnar nerve palsy and you look for a snapping ulnar nerve. Then your diagnosis will look towards an infective cause. That means leprosy or whatever. First rule out the physical causes. Look for scars, obviously. Look for a history of injury. But these things may hide and you may not get this history properly. Yeah? So your history taking has to be extremely good. There are, in claw hands, there are other things that you need to look for, and that is the unassisted angle. What is the angle of the claw? That means as it stands, what is the angle? Assisted claw, which is the Bouvier maneuver done. That means how much correction you need to do to get the IP joints extended. That means your surgery has to correct the MP joint flexion up to so much. Okay? If you cannot correct it because there is a contracture, then you have to look for the angle of contracture. That means this much stiffness. That means there is so much of a lag, or there is stiff joint so much. Sometimes you may find that it's a hypermobile finger, and very rarely there might be adaptive shortening. Forget about the adaptive shortening. This happens in chronic long-standing cases, and no examiner is going to ask you or trouble you with that. Okay? So you're looking for suppleness of the finger. You're looking at joints with contractures. You're looking at joints with hypermobile joints, which are all reasons where your treatment is going to change a little bit. Okay? What is wrong in this patient? He's been asked to extend his wrist and fingers. So there is a wrist drop, right? So when you say there's a wrist drop, you also look for which muscles will you look for proximally? Brachioradial is first, and then the triceps. Okay. This is after the surgery, of course. When you're dealing with the median nerve, I don't think I should impinge on other people's topics, but then there are certain tests which you're going to ask the patient to do, and in addition to the test, there are clinical signs that remind you that this is a median nerve problem. When you're talking to the patient, when you're taking history, always make it a very nice interaction between you and the patient. Try and be a little humorous in a very subtle sort of way. Or try and touch upon personal things, like when you're dealing with the median nerve, you must know what is the problem. The problem is that the patient's thumb is weak if the motor problems have already started, right? Ability to hold things becomes a little difficult. So you ask the patient certain questions, like what my questions to the patient usually are, and I write them down on my paper, which is of no medical legal value or anything. But it helps me to know that the patient is going through a certain amount of problem. Number one is nocturnal symptoms. You ask the patient that at 3 o'clock, the moment you say 3 बजे रात को नींद खुल के ऐसा करना पड़ता है, you make a face and immediately the patient will, हाँ sir, you touch that raw nerve, you know, that every night they go to sleep like this. Now why are they getting this at 3 o'clock? Because the Phelan test is slowly becoming positive. They're sleeping like this or they're sleeping like this. The Phelan test is becoming positive. So then they wake up around 3 o'clock and they have to do this, and then they're a little better, then they go back to sleep. So you ask the patient now will come up with more symptoms and signs. You ask the patient, paper पढ़ सकते हो? What is paper? The reverse Phelan test. You're sitting with hyperextension. So newspaper, not the new small tabloids. Okay, the big ones. Okay, so newspaper, that's another question. You ask them and immediately they're like, oh yes, of course. And a woman, she's gone away, but a woman, no woman cannot have done this at least 1,000,000 times in their lives. You're in a hurry to go somewhere, you're putting the earring, the little knob falls down. You ask the lady, when you do this, don't ask, chota cheez uthane mein takleef hai, you have trouble in lifting up small things. They'll say no. But you tell them this specifically, that when you're putting your earring and it falls down, is it difficult to pick it up from the ground? And they will invariably smile and almost come out of their chair and hug you. Because you know them so well, you know them so personally. Every wife does this, every lady does this. You tell them sit on the bed, there's a white bed sheet and do it. If it falls, it's right there, you idiot. No, but they won't do it. They'll stand in front of the mirror. If they have a median nerve problem, they cannot lift fine objects. So that is how you ask the history, you know. You elicit this history. These are signs that there is a motor wasting, whether you clinically see it or not. We'll see other signs that we can see. The other sign is a Burrell angle. The Burrell angle is one of the finest, earliest sign that tells you that the motor wasting has occurred in a carpal tunnel or a median nerve associated problem. When you oppose your thumb, and this is the reason why you cannot hold a small fine object, because the thumb approaches the finger from an angle that is more than 15 degrees or 20 degrees. The normal nail to nail with the ring finger is 15 to 20 degrees. Look at your own nail, 15 to 20 degrees. If you have it more, we are opening the theatre just now, you can come, we'll operate you. Okay, so that's the angle that should be. The more this angle increases, the thumb has to come from the side and it cannot therefore then pick up fine objects. So it's telling you the reason for not being able to pick up this. So the Burrell angle is extremely important when you're dealing with the median nerve. Okay. The other thing is the Kappanji score, which also is telling you about the reach of the thumb into a position. So you start with, on the index finger here, 1, 2, this is the Kappanji score, to tell you the good function of the thumb. So you can say Kappanji 1, 2, 3, 4, whatever is possible. If the patient is unable to go beyond this, or if the patient is going up to here, then you say Kappanji 5, 6, 7, 8, 9, like that. Okay. So you know the function of the FPL as well as the opposition. It's a combined score. It's not something specific for median nerve. Okay. And one very nice sign is to look, ask the patient to say "Bahut acha," very nice. And if you cannot, and if you see on the left side, if you see on the left side, what you're seeing is the patient is unable to make a perfect O, which again is a position which requires complete opposition of the thumb. So when the patient cannot make perfect toes and it looks oval like that, there's already motor wasting. You don't need all of this, you just look at the thinner wasting. But why am I stressing this? Because if the left hand is involved, the right hand is involved, it's okay. If the left hand is involved, very often the thinner eminence on the left side is less prominent normally. So how do you differentiate? If the power to do this, if the Burrell angle is normal and there is a little flattening, this may be physiological flattening because we use our right hands more than the left. So you should be able to explain to the examiner why I do not think that the median nerve is affected or why I think the median nerve is affected by reasoning out these two. Okay. There are other things which we don't have in our exams, that is algometers, dolometers, monofilaments, etc. Just for your knowledge, when you're writing a paper on median nerve, you must be able to answer these. These are called von Frey's monofilaments. These filaments, when pressed against the skin, depending upon the thickness of the filament, do not cause unpleasant sensations. But when they do cause it, that means there is some paresthesia. So when you have paresthesia, you can test. You also look for 2-point discrimination, which is examined by a very simple device. That is, you take an office clip and you measure 1 millimeter, 2 millimeters, 4 millimeters, 8 millimeters, whatever, and you say that the 2-point discrimination. What does that mean? You ask the patient to shut their eyes and you ask them, and you touch one prong or both prongs, and you ask them 1 or 2, and they tell you whether they can make out there are 2. The least distance at which they can differentiate is important. Okay, so around 2 millimeters is good, around 5 or 6 millimeters is bad. Anything in between, maybe your test has to be interpreted again. It's not perfect, but it's something that you can try. There is a device called the Manifeld device, if your examiner asks you for that. There's also a grip meter when you're examining hands. There's usually the Jamar grip meter, which tells you how much pounds per square inch, etc. you're pressing down. Okay, now here's another patient with clawing. What is the cause in this one? Does it look like clawing? What is clawing? The definition of clawing is hyperextension at the MP joint. Is this clawing? It's not. So very often students are prone to seeing a flexed finger and say it's clawing. There is a problem with the skin. There's a problem. You can see that there is a, what is this? It's a deep contraction. It's very commonly seen in the exam. So learn a little bit about the normal, learn a little bit about the abnormal, and then you will know what deeputans is. Okay? We won't go into details. When you're dealing with swellings, okay, remember swellings like this. You have to go through the entire KC Das or K Das or whatever, not KC Das. KC Das is the sweet shop, right? Yeah. So the K Das thing of swelling, when you see what all do you see when you see a swelling? Louder, yeah. Yeah, size, shape, consistency. Yeah. So whether it's warm or not, and then fluctuation. In the hand, cross fluctuation across into the palm. Extremely important because you get what are known as compound ganglia, right? So you must also remember that. We won't go into too many details of that. The other couple of points that I'm going to make about examining rheumatoid arthritis. Yeah. Now when you see a rheumatoid arthritis patient, it's like spelling, that ghanti baj gaya tera. It's time to say that I'll come next time, because it's a little difficult one. Because even if you give me, or I'm sure if you give Ashok a rheumatoid hand, we are a little out of depth for that. There's so many things happening together, each finger behaving differently, each finger in a different stage. So please be very specific when you're talking about a rheumatoid hand. Don't just say that there is a swan neck deformity and forget about it. There may be 2 swan necks which are correctable and 2 which are not. The treatment for the first 2 will be different from the treatment for the second 2. There may be 3 sublux joints and 1 normal looking joint with only synovitis. So it's very tricky. So examine each joint, look where the extensor tendon is before you start flexion and when you start flexion and when you finish flexion. It slips towards Towards which side does the extensor tendon slip? To the ulnar side. It's called ulnar subluxation or guttering. It goes into the gutter or into the space between the two metacarpals, right? Once it goes there, very often it can come back. So it is a correctable ulnar deviation or ulnar guttering or ulnar subluxation. Sometimes it goes and gets stuck there. So it's a permanently subluxed one. When it gets stuck there, it then starts pulling the MP joint into flexion, and then you get uncorrectable deformity. So you've got to mention whether it's a correctable deformity, whether the tendon is functional or not. So that is again telling you what your treatment is going to be. Okay. And finally, when you get to see the X-rays, whether the joints are destroyed or subluxed, they make a difference, because then you're going to not talk about the soft tissue treatments. You're going to talk about joint replacements and arthrodesis in these cases. Yeah. You see the ulnar guttering here? Sorry. It's pretty clear here, right? You can see this tendon is right down the center. There's synovitis there, and you can see the ulnar guttering there. Same thing with this. You see the synovitis there, and you can see the ulnar guttering, and that's why the little finger has started. So this is the early stage of the deformity. Okay, you can stage that into synovitis, arthritis, and complete destruction. Yeah, and forget the treatments, etc. Basically, running out of time, so it's very difficult. The important thing when you're dealing with, say, boutonniere or a swan neck, yeah, number one is to identify that it is a boutonniere or a swan neck. There are two names which are like, very foreign names for us. If you say Thomas test or you say Shenton's line, you have images coming in your head. You say swan neck, you have blank spaces coming up, little gray areas. So it's very difficult. Understand that you are looking for flexion or extension at the PIP joint. Okay, when it's flexed, it's a boutonniere. What is a boutonniere? It's a buttonhole deformity, which basically means the extensor tendons which go from the sides have separated out, just like this buttonhole has to separate to allow this button to come through. So the button is the head of the proximal phalanx, which then just juts out. So that buttonholing causes flexion, because now these tendons cannot come back up and extend the finger. So it's a correctable, not correctable, which means there's subluxation of the lateral bands, and there is the triangular ligament there has stretched out too much and allowed it to go down from the sides. So now it's below the center of rotation, the axis of rotation, and therefore cannot bring it back into extension. Okay. When you're looking at this secondarily, because the tendons have this thing, that my job is to pull the PIP joint up. So he says, pull the PIP joint up. The PIP joint says, I'm not coming up. Says, pull the PIP joint up. I'm not coming up. Pull the PIP joint up. The DIP joint goes into hyperextension. So what is that? A secondary effect of an over strong intrinsic trying to pull the PIP joint and not doing so, eventually puts all its force on the DIP joint, and that's the secondary deformity. Okay, so exactly the opposite occurs when you get a swan neck. Okay, these fellows are meant to flow during flexion and come back up. When they get stuck on top, they don't flow, so then they get into hyperextension. So these lateral bands are now stuck, the triangular ligament there is very tight, and therefore they don't go down. Now in that, your flexors keep pulling the DIP joint into flexion, and you start getting a mallet deformity. So you can get an uncorrectable mallet, an uncorrectable swan neck, etc. So depending on that, your treatment will vary. If it's an uncorrectable one, and if the X-ray shows arthritis, then you're thinking in terms of fusions. When it's an uncorrectable one with a soft end to the, so you must mention this, sir, there is a little give in the joint, and the X-ray looks clear, there doesn't seem to be arthritis, I would think in terms of doing a soft tissue procedure. So again, you're giving the examiner the chance of understanding that you know that it's not progressed to the stage of arthritis, it's still in the stage of synovitis, and therefore you can still do something, and the stage of deformity, that you can then still do some form of corrective treatment. Okay. Yeah. When you're dealing with congenital deformities, I think it is sadism on the part of the examiners to give you a congenital deformity in the exam. Because children won't behave, children will run away, children will not listen to you. So it's always very difficult. So always examine the child. Don't rush to any child. When you go to your relative's house who has got a newborn baby or a baby who's say a year old or 2 years old, you go first thing and you say, first thing you want to show that I also care for this baby, his child, but I also like this baby. You want to show, no, because you're the mama, you're the kaka, you're the chacha, whatever. So you first thing you go. One thing is you hate it because this fellow is leaking from his nose, his diaper is wet and he's all food all over and there's all milkmaid and God knows what all other things are all, and you go and you baby, and you take him and the fellow starts screaming like hell. And then you no, etc. But if you really want to take the baby, don't even go near the baby. Don't look at the baby also. Just hang around for a while, talk to the parents, hold the other hand of the child. Take a pen and just tickle the hand, so he'll hold the pen. Then slowly go to the hand that you want to examine. The child will allow you to examine. So be very careful. If you get a pediatric case, don't rush. Don't yank the hip and don't yank. They'll just shut off. And then you are going to have my I had 3 children for my short cases. 2 were polio and 1 was I don't even know what, because even the examiner didn't get to find out. They were all over the hall. So I'd chase one fellow and he'd go. So I would run behind him, catch him and put him down somewhere and try and examine him, by which time the other fellow would come running from there and show me his hand and show me. Then I was suddenly interested, he's showing me the hand, I'll go here. So when you have children, be very careful how you examine, make notes, because you will not get the same finding 2 times. So make an average of 2 or 3. Be sure in your mind, because the flexion deformity matters. Your treatment will matter. If you're dealing with the hip or the spine, it's a big problem. Yeah? When you're dealing with polio kids, and you don't see them very often, but if you do, unfortunately, or get a cerebral palsy child, they'll be sitting like this. Next moment they're sitting like this. And you tell the examiner there's an incorrectable deformity and the patient is sitting there with the mother like this. You said wrist is 30 degrees flex, sir? Sir, when I saw it, why was that? So always say, sir, I would like to examine the child in 2 or 3 sittings. When the child is comfortable to be examined by me. Air conditioners. Half the children have never sat in an air conditioner. So they're very uneasy at that. Hypermobile child, the hyperactive children, they're all over the place. They're jumping on your back, they're pressing this, they'll pull this up, push this down, then they'll come and stand there. So you have to be very careful when you're examining children. Yeah? And if you're not very sure, then tell the examiner. Some terminologies you must remember. In syndactylies, which are common, which you might find in your exams, you must see whether they belong to equal fingers or unequal fingers. Okay, that's number 1. Number 2 is see whether the joints are mobile and whether they are all symmetrically mobile. If they are asymmetrically mobile, that means there is some delta phalanx or an extra phalanx or something else that is making it into a complex syndactyly. So you divide it in your mind as to simple syndactylies which are just cutaneous, or a complex one which involves tendons, nerves and other things, bones. So this is important. Second thing is whether it is entire length or not. So you say it's a complete cutaneous syndactyly or it's a complex or incomplete, depending upon, involving unequal fingers. The moment you say this for an examiner, it's like you got the gold medal. Because if it's uneven fingers, there is an urgency to operate. Because this will restrict and cause permanent deformities in the other one. So when it's of similar fingers or similar length fingers, you may wait a little longer. You already told the examiner, I know a little more than you, sir. Yeah? Remember also, when the fingers are smaller, they are called brachydactyly. When the fingers have stiff joints, which are common when you have a complex, so you say it's a symbrachydactyly. Yeah? So you have 2 or 3 terms to know. Don't have to know all the diagnoses, etc., etc., etc. Yeah, this is a mitten hand where all fingers are almost equal. And then you can separate them and they do a little better. and the radial club hand. Remember, when you're dealing with the radial club hand, again it's a very rare thing that they'll give you in the exam, but if you do, then you must remember that it's associated with a lot of other congenital problems. And the moment you point out to the examiner that I'll get a complete blood count done, why? Why complete blood count? Thrombocytopenia. I'll also get a pediatric cardiology opinion. So you're telling the patient, the doctor, that, and I'll get an X-ray of his spine. So you're telling the doctor that you know what are the other conditions associated with this, and therefore you always are on a better wicket. Then you talk about correctability, whether there is a presence of a radius or not, etc., etc. Okay, rarely you'll get macrodactylies. Because they look nice, they'll bring them to the exam, and then they'll start troubling you with what treatment will you give. I normally tell them I'm going to remove the finger, which is very difficult to convince, but then probably is the best answer. Trying to reduce them becomes a little problem. But when you're going to reduce them, remember, you need to do epiphysiodesis. You need to do defatting or debulking of these fingers in multiple stages, one side at a time. That's all the examiner wants you to tell him. And also that very often these are associated with nerves. This is a digital nerve in a patient who's got gigantism. Now you cannot cut this nerve off without taking away the sensations. If you don't cut this nerve off, you're not going to debulk it. So when you open it, it becomes very difficult to do an intraneural debulking of these, where you maintain the fascicles and take out the fat. So these are the problems, and these are usually called NTOM, or nerve territory oriented macrodactylies, usually in connection with the median nerve. So you'll find that these three fingers are usually affected. Yeah? And finally, if you get a case like this, after you've examined other cases, then you can be sure that you are headed for gold, because no examiner will give you something like this unless he knows that you want, he wants to bring out the best in you. Because this is a combination of everything that we spoke about. Number one, the bones and joints. Number two, the soft tissues. Number three, the skin. So each and everything is involved in this. When you get a case like this, you are very, very dejected. Start with the skin. Write down the condition of the skin, whether it's good, whether it needs replacement or not. Then look for the nerves. Look for the function of the tendons. Look for the joints. So you mentioned each and everything. So that gives you an idea. When you've shown the X-ray, you obviously then will have much different ideas about this. But if you go logically, even a case like this you can break down into very easy this thing by talking about the skin separately, by talking, don't say it's a crushed hand with deformity of this thing, that thing, etc. You start by saying the skin looks like this, there is no tendon function, or there is some tendon function, but it seems to be at the other end. So and so tendons are not working. The sensations are poor at so and so point, the vascularity looks fairly stable, and there is instability at the joints, and I would like to see an X-ray. So, there's collapse or instability, and I would like to see an X-ray. So when they show you something like that, then you can go on to discuss something further. Okay? Well, I think this is not very wrong. Most of us spend a lot of time trying to make lectures which are very smart and things like that, but usually most of the students are always asleep. So that's why I'm going to keep asking questions. And the next time I'm going to ask you more questions, and I want more louder and quicker answers. Okay? Sure. If there's any questions, it's not a complete way of examining the hand, but it's a way of starting to think what you're going to do when you see a hand case. Finally, like I said, for any examination, remember every test has to have a logical reason why you ask for that test or why you're doing that test. It either diagnoses something for you, confirms what is wrong, or tells you what to do for treatment. Then your examiner knows you're a practical person, you're not just rectifying stupid stuff in the book. Because there are many, many tests in the book, and you don't need to do all tests. If you know the test, and if you know that this patient has got this, and you've got to do these 3 tests, and you've got a diagnosis and a treatment ready, the other tests are superfluous. If the examiner asks you and says, sir, this test has not too much value, because this is this, then therefore I wouldn't. Like the 3 tourniquet test in the when you're doing the varicose veins, you find these fellows tying this and making them walk for 15 minutes, 3 tourniquet, this thing, that. 3 tourniquet bandne ka is such a bloody pain. And then to maintain that and walk behind the patient, don't loosen one like this, like that, like that. It's all stupid because it makes no sense. If you if you understand what you're trying to do, is there incompetence here? Is there deep vein thrombosis? 3 signs, that's it. Is there an ankle flare? Which ones are you going to tie up? Finished. Practically you got everything organized. Similar to that in the hand. Get everything organized in your mind. What is the diagnosis? What are you going to do? And why you're going to do it? And these tests corroborate either the diagnosis or my treatment. Thank you very much. Right? Okay.